Okay, my name is Katie Grace Daniel. Here's my act card. And you gave me permission to do this assessment on you.
Yes, ma'am.
Okay, so we're gonna first start by inspecting the posterior chest, and we're looking for any like skeletal deformities that could, we're looking for any skeletal deformities. We're looking at the thoracic cage for any skeletal deformities that can limit excursion. So we're gonna first start by looking at the slope of the ribs, and the ribs should be inverted at a 45-degree angle. And abnormalities we would see would be barrel chest, which is like a rounded appearance of the chest. It has horizontal angle, the ribs are horizontal. There'd be like slight kyphosis and a prominent sternal angle. You could also have kyphosis, which is a humpback appearance, and this is a curvature of the thoracic spine on the posterior chest. And then we have lordosis, which is like a curvature shape on the lumbar part of the back. And then we have scoliosis, which is an S-shaped curvature of the thoracic and the lumbar spine. And to assess this, we're gonna have the person stand up, and you're gonna have the person like bend over horizontally, and you're looking first at his spine to see if there's any like S-shaped curvature, and then you're looking at like the sides of his ribs to see if his hips are unequal, the scapula is unequal, and the shoulders unequal. So you can sit back down. And then other abnormalities would be pectus excavatum, and pectus excavatum is also known as funnel chest, and it is when the sternum is like sunken in, and there is you can see like the adjacent cartilage. And then we have pectus carinatum, which is also known as pigeon breast, and that is when there's like an outward protrusion of the sternum. So we're also going to inspect for the skin color, and we're looking to see if the skin color matches their genetic background, and there might be like sun exposure spots on the chest and the back, but like that's okay. And you also want to note that the position the person takes to breathe, just as like they're breathing through their mouth, and they should be like a relaxed posture, their hands at their sides or their hands in their lap, and everything's fine. And then we're also going to inspect for any involuntary respiratory movement, and this is what person, again, just breathing through their mouth, and you're going to inspect for any unequal chest expansion, and that like their chest is moving like simultaneously. So after we inspect, now we're going to go to palpate, and we're palpating using our fingers of our dominant hand in a rotary motion, and we're palpating for any masses, tenderness, sinus tracts, and crepitus. So we're going to go ahead and palpate. Okay, so we're also going to palpate for the symmetric respiratory excursion, and this is to see if it's the range and the symmetry of the respiratory movement. And in order to do this, we're going to pinch a piece of skin at the T9 and the T10 level, and when they breathe in, your fingers should go out, and when they breathe out, they should go in. So first we're going to have you cross your hands across your chest, like just fold your arms to get the scapula out of the way, and we're gonna pinch the piece of skin and breathe in and breathe out. Okay, so we're also going to palpate for tactile fremitus, and tactile fremitus, you're looking at there's like a strong vibration and it's symmetrical, and we're gonna use the palmar surface of our hand at all the different points, and we're gonna have the person repeat either blue moon or 99. And tactile fremitus is going to be strongest in between the scapula and over like major bronchi. So say 99.
99.
99.
99.
99.
99.
99.
99.
99.
99. 99. 99. 99, 99, 99.
Okay, so now that we're done with palpating, we're gonna move over to percussion. And when we're percussing, we're looking to see if it's fluid-filled, air-filled, or solid. So we're gonna get our percussion hammer. Okay. Now that we've done percussion, we're gonna move over to auscultate, and we're auscultating the back of like his lung tissue. And when we're auscultating, we're listening for like normal breath sounds, and we're listening for adventitious breath sounds. The normal breath sounds would be bronchovesicular, which is like a moderately pitched, and this is loudest in between the scapula, and on the posterior side, it's loudest in between like the sternum at the first and second intercostal spaces. And we're also looking for vesicular breath sounds, and vesicular breath sounds is going to be loudest over the periphery of the lungs. And then absent or decreased breath sounds is going to be due to a bronchial tree obstruction. Your adventitious breath sounds are your abnormal breath sounds, and this includes crackles, which is it's due to like air going through in like an abnormal passageway, like an abnormally moist passageway. And then we have wheezes, which is a higher pitched noise, and it's due to the narrowed small airways. And then we have bronchi, which is more of a sorry, dog, is more of a rattling noise, and it's due to and it sounds like a moan, groan, or snore, and this is when it's like a constricted or narrowed large airway. And then we have friction rubs, which is more of like a grating noise, and it's due to two inflamed or roughened pleural spaces rubbing together. And we also have stridor, which you can hear a lot of times without the stethoscope, and it's like when they're like on inspiration, and it's due to an upper airway obstruction. So now we're gonna auscultate. Okay, so now that we're done with the posterior chest, we're gonna move on to the anterior chest. Do you mind turning towards me? Thank you. And we're looking on the anterior chest for the respiratory, like the respirations, like the respiratory rate and rhythm. So a normal respiration should be anywhere from 12 to 20 breaths per minute, and the rhythm should be regular, even, and unlabored. And abnormal like respirations would be tachypnea, which is an increased but shallow respirations of greater than 24 breaths per minute. And then you have bradypnea, which is a slower breathing, but just because it's decreased, there's still like a regular pattern. It's less than 10 breaths per minute. And then you have apnea, which is a complete like not breathing, and it may be periodical. And then we have hyperpnea, which is an increase in the depth of the breathing. And then we have hyperventilation, which is increase in the rate and the depth, and hypoventilation is like slow breathing in like an irregular pattern. And then we have Cheyenne-Stokes, which is the respiration is like a regular cycle of like waxing and waning, and you'll have an increase in the rate and the depth, and then you'll have a decrease, and this can last anywhere between 30 to 45 seconds, followed by apnea in between. Then we have Biotes, and Biotes is like a form of Cheyenne-Stokes, but it's like it's an irregular pattern, and it's when there are normal respirations, like 3 to 4 of them, followed by a period of apnea, and this can last anywhere between 10 seconds to 1 minute. Then we also have Kussmaul's, which is like a panting, like labor breathing of an increase and a decrease, an increase in the rate and the rhythm. So after we look at his respirations, we're going to move over to the width of the coastal angle. And the width of the coastal angle is like right here. It's like the brim of their ribs. And it should be anywhere between, it should be 90 degrees or smaller. And we're also going to inspect if there's any accessory muscle use. And we're gonna want to look at his trapezius, his sternocleidomastoid, and his like abdomen area. So after that, we're gonna inspect and measure the AP to lateral diameter, and the AP diameter to the lateral diameter ratio should be 1 to 2 in a normal adult. And in an aging adult, the AP diameter may increase, which is all normal. And we're going to measure this in inches. So will you raise your arm for me? So we're measuring the AP diameter right now, which is about 7 inches. And now we're going to measure the lateral diameter, which is about 15 inches, which is the normal ratio. So after we inspect, now we're going to move on to palpating. And again, we're palpating for any tenderness, masses, sinus tracts, and crepitus. And when you palpate on tactile fremitus, you're going to use the same technique, and you're going to either repeat 99 or Blue Moon. But you want to note that tactile fremitus over the pericardium, which is the part of the chest that covers the heart, and the breast tissue. Well, breast tissue is going to be completely absent. Over the precordium, it might be like a decrease or absent, but in like your females, over their breasts, you're not going to feel tactile fremitus, and you may have to displace the breast in order to like proceed with your tactile fremitus. So now we're going to assess tactile fremitus. So 99,
99,
99,
99, 99, 99, 99, 99, 99, 99.
Okay, so now that we've done tactile for the palpating, we're going to move on to percussion. And here we're trying to see if it's fluid-filled, air-filled, or solid. And then you know the parts over the pericardium are going to elicit a dull sound. Okay, so now that we're done with percussion, we're going to move on to auscultate. And we are auscultating for normal and adventitious breath sounds. The adventitious breath sounds is going to be your crackles, your murmurs, your rhonchi, and your stridor. And the normal breath sounds that you're going to hear is your vesicular breath sound again, your bronchovesicular breath sound, and you're also going to hear a tracheal breath sound, which is a higher pitched breath sound heard over the trachea. Okay, so now we're done with the anterior part of the chest, so we're gonna have the person move over to the couch where they're gonna be laying down at a supine angle, and we're gonna be on the right side. So we're gonna first start by marking and inspecting all the precordial points. And the precordial points, we're gonna start by finding the angle of Louise, which is right here. So I'm gonna go ahead and mark that. And now if you move over laterally to the right and to the left, on the left side and the second intercostal space is going to be your pulmonic area. So we're gonna mark that. And then if you move over to the right is gonna be your aortic area. Then if you go down to the third intercostal space, that's where your Erbs area is going to be. And then the fourth and the fifth is going to be your tricuspid area. And then if you look at his, if you go to his mid-clavicular line and you go down medial, and this would be his fifth intercostal space, which is the mitral apical area. So after we locate all the precordial points, now we're going to go to inspect the precordial points. And when we do this, we're looking for any lifts, heaves, abnormal pulsations. A lift is a slight movement. A heave is more of a vigorous movement. And we're gonna do this all at eye level, but I'll do that in a second. And a heave is due to a forceful thrusting of the ventricle movement during systole. And a right ventricular heave you can see at the sternal border, and a left ventricular heave you can see at the apical mitral area. And when we're inspecting, we also want to look for an apical impulse to see if there's any lifts, heaves, and abnormalities. So we're going to squat down to eye level, and we're looking at all the precordial points in the apical area for any the lifts, heaves, and abnormal pulsations, which there are none, so we're good. And then after we inspect, now we're going to move to palpate, and we're going to palpate with our dominant hand in a rotary motion again, and we're palpating all the precordial points for any lifts, heaves, abnormal pulsations, and thrills. And thrills is a palpable murmur. And we're also going to want to palpate the apical area, and when we do this, we're going to use our middle finger of our dominant finger pad. And a lot of times the size is 1 by 2 centimeters. And when we do this, we're going to have the person exhale and hold their breath. But first, we're going to start by palpating all the precordial points. Okay, so now now exhale and hold your breath. Okay, you can breathe. So after we palpated, now we're going to go to osculate, and we're going to first start by osculating the apical rate and rhythm with the diaphragm of our stethoscope, and this is where we are checking. We're checking for the rate, rhythm, and quality. So then we're going to go osculate the rest of the precordial points, and we're going to use the diaphragm and the bell of our stethoscope, and we're going to have the person just breathe through their nose regularly. And when you osculate, you want to osculate a full cardiac cycle. So the first heart sound that you're going to hear is due to the closure of the mitral and tricuspid valve, which are the AV valves. The second heart sound you would hear is due to the closure of the aortic and pulmonic valves, which is the semilunar valves. And then extra heart sounds you may hear is the third heart sound, which is like a low-pitched sound you hear with the bell of your stethoscope, and it is also known as a ventricle gallop, and you're going to hear it after S2. And then the fourth heart sound that you may hear is again a soft pitch sound used with the diaphragm of or the bell of our stethoscope, and it's known as an atrial gallop, and it is heard right before S1. And then you may hear a split S1 sound, which is when the mitral and tricuspid valves are not closing at the same time. And you can hear a split S2 sound, which is when the pulmonic and aortic valves are not closing at the same time. And then we could hear an ejection click, which is when it's like a stiffy, like the movement of a stiffy deformed valve. And then we have a mid-stolic click is when the mitral valve balloons into the left atrium, producing this click. And then we also have murmurs, and murmurs are like a harsh blowing sound. And this is due to like the blood flow going through a like an abnormal passageway. And then it could also be the shunting of blood. The blood flow would be going through like a defective valve, and the shunting of the blood would be going through like an abnormal passageway. And when you're listening for murmurs, you want to assess the time, the location, the transmission, the radiation, the quality, the intensity, and the pitch. So we're going to first start by auscultating with our diaphragm, and then we're going to switch to the bell. So now we're going to switch to the bell to listen for the extra heart sounds. Okay, and then now that we're done with the whole like heart assessment, we're gonna move over to the assessing the non-cardiac perimeter due to like the cardiac function. And signs of like poor blood perfusion to the brain would be like foggy senses, decreased alertness, and like frank disorientation. And other signs you could see is like a rapid decrease in the visual acuity and hearing. And there could also be like a sudden like decrease in the locomotion and reflexes. And if there's not enough like blood perfusion, you're gonna have like your vital organs are gonna be affected. And oliguria is like scanty urine production, and this is due to like a decrease of blood perfusion to the kidneys. And you have anorexia and constipation, which is due to it's like mild perfusion of the GI tract. And then we have air hunger, which is when there's like your lungs aren't receiving like enough like oxygenated blood. And then we have hepatic engorgement and like pain, tenderness over the right upper quadrant of the abdomen. And this is due to like the heart has like a decreased ability to receive and pump venous blood. And that's all.
Make sure to catch Dixie chewing on her bone, since I was in the background the whole time.
That's the dog.